Hi, my name is Victoria Sokolova, and I'm a rising fourth-year medical student at the Medical College of Georgia. And I'm going to be talking about a case report about encephalitis of unknown origin in a patient with renal cell carcinoma. So the chief complaint was that our patient was sent from her home by her neurologist due to altered renal status that had failed to resolve, and they wanted her to be admitted to receive an MRI, basic labs, and a neurology consult. So HPI, a 78-year-old woman with a past medical history of renal cell carcinoma, diabetes mellitus, hypertension, and chronic kidney disease, was directed to the emergency department at our institution because of persistence of altered renal status. Of note, the patient was diagnosed with renal cell carcinoma in December 2021 after she developed gross hematuria, and she underwent embolization via interventional radiology at an outside facility. And following this embolization, she had to be admitted to the intensive care unit because of neurologic decline after the procedure. And it was initially suspected that she had developed toxic metabolic encephalopathy following a urinary tract infection, or potentially had delirium just associated with hospitalization. However, her altered mental status persisted following resolution of her UTI and hospital discharge. And following discharge, her altered mental status continued, and she had also then went on to develop spastic quadriplegia, expressive aphasia, disorientation, and had outbursts of yelling. In July 2022, she underwent a second embolization procedure, and her family reported that she was mentally lucid for about 48 hours after the second embolization. However, this did not persist, and she then developed altered mental status again, and again had the spastic quadriplegia, expressive aphasia, disorientation, and yelling. When our patient presented to our emergency department, a review of systems was unable to be fully obtained due to her altered mental status. However, some pertinent findings on neurological exam was that she was found to be awake, alert, oriented to person, place, and time. She partially followed most simple commands and was able to do some simple math. However, her abstraction was impaired in addition to her attention. Some physical findings was that her muscle bulk was decreased while tone was increased throughout the lower extremities, worse than in her upper extremities. Her hands were found to be in a flexed position where she was unable to relax her hand grip in both her left and right hands. However, she was unable to relax her left hand grip so much so that she needed botulinum toxin injection during this hospital stay just so she could relax. Both of her feet were plantar flexed bilaterally, and she was unable to perform dorsiflexion. Her coordination was not able to be assessed because she was unable to cooperate, and her gait was unable to be assessed as well. At our institution, an MRI of the brain and cervical spine and CT of the brain were found to be negative. However, due to the history of her family reporting that she was mentally lucid for 48 hours after the second embolization, there was some concern of a possible paraneoplastic encephalopathy going on, and a cerebrospinal fluid analysis was sent to the Mayo Clinic laboratories. However, a autoimmune encephalitis panel was negative and did not result in anything. And during this admission, she received IV immunoglobulin, to which her family reported a mild improvement in her symptoms. A CT scan that was done at our institution was significant for a 7 by 8 by 8.5 centimeter left renal mass. And when this mass was biopsied in February of 2023, a diagnosis of clear cell renal cell carcinoma was confirmed. Treatment with cabozantinib was initiated as she was deemed not a surgical candidate. And this is our patient CT scan. So as you can see, there is a considerably sized mass in her left kidney. And again, this mass was confirmed to be clear cell renal cell carcinoma. So some key learning points. Paraneoplastic syndromes are relatively uncommon. Classic paraneoplastic syndromes are typically associated with small cell lung cancer, testicular germ cell tumors, and thymomas. Renal cell carcinoma has not been typically associated with paraneoplastic syndromes. However, there have been a couple of case reports where they postulated that clear cell and chromophobe renal cell carcinoma led to development of paraneoplastic neurologic syndromes. However, in our patient's case, the true etiology of her encephalitis remains unknown. Altered mental status is a relatively common finding among patients with malignancy. And in fact, cancer patients are found to have a 57 to 85% incidence of confusion compared to 15 to 30% of hospitalized patients without a malignancy. The etiologies behind altered mental status are broad and can include metabolic or immunologic derangements, brain metastases, and they can even be attributed to certain therapies that are used to treat the malignancy itself. The delay in diagnosing altered mental status can lead to prolonged hospital stays, in addition to increased morbidity and mortality for these patients. And once again, while certain cancers are associated with paraneoplastic syndromes, which themselves are very rare, renal cell carcinoma has rarely to be even identified as a potential cause of such a condition. Altered mental status can present in a variety of ways, including cognitive decline, behavioral changes, and psychiatric symptoms. And for our patient, her case demonstrates the complexity that can arise with diagnosing the etiology of altered mental status in a patient who presents with malignancy. And that is our case report. Thank you.